There we go. So, can everyone see my slides? Is it okay?
Yes, sir. Malino, sir.
Thank you. So, good morning. I'd like to thank Doc Billy for inviting me, Dr. Douglas, and the rest of the PSGS Metro Manila chapter for their very gracious invitation. Sorry, let me just fix my screen. Okay, there we go. Okay, so good morning, I'm Dr. Erlina. So as an overview of my lecture, we only have, I was assigned 1 hour, as you know, so I will assign 30 minutes for the esophagus, 30 minutes for your stomach. Uh, this is by no means a comprehensive um, lecture of everything, no, as you would expect. But I hope to at least a little bit try to help you in your exams. I have around 131 slides, so I'm very sorry for that. But I'll be breezing through some of them. Um, if there are some details there that you would like to take screenshots of, there's really no problem. I'll just point them out and then you can come back to it later on. But I would like to slow down on some of my slides, particularly in the slides that pertain to the basic principles of our organ system. Because I'm not very smart, I cannot remember everything, I cannot memorize everything that I've studied. But if I have the basic principles uh, solid right within me, more or less any question that can be asked of me or any clinical scenario, I can more or less deduce what is the rational thing to do in that situation. Okay, so I in my lecture I will stress on those things rather than the little minute details. Okay, and also feel free to take screenshots for later review, and I think we will be providing you with copies of our slides. Okay, so I hope to finish uh, before lunch. Okay, here we go. These are the sources that I use. So these are available to every one of you if you would like to review or you would like to go deeper into the topics. So these are the following textbooks. And I took particular, you have to download the Japanese Gastric Cancer Guidelines. Your NCCN guidelines have to be updated. And the other journals that I use are stated right down below each slide. There, as you can see, and as you know, no, it's very frustrating for us when we study. There will be some conflicts between the sources. Okay, so I will, if ever we come across any of that, I will point out those conflicts. So at least you will be ready kung ano man ginamit ng examiner resource, you would at least try to figure out what is the best answer. Okay. Okay, I'd like to start with this quote from Fisher Master of Surgery. And it says, surgically, the gastroesophageal and the gastroduodenal junctions are perhaps the most difficult anatomic units in the operating room. And this is something that you can validate with your experience. And it is not just to technique-wise, it is challenging, of course, but also prognosis-wise, you know, um, outcome-wise, it is very, very challenging. And that's why we continue to study, we continue to try to hone our skills and to learn as much, you know, and to employ all of the available data that, oops, all of the available data that is that we can use. Okay. So let's first start with the esophagus. So I would suggest for every one of you, for your oral exam or for any of your exams, is to make your own study outline. Just simply just list everything down, and then make sure that when you pick one of these things, you will have something to say about each one of them. in terms of diagnostic. How do you diagnose? What are the physical exam findings? What is the clinical picture basically? And then what is the diagnostic test that you request? And then what is your treatment? Right? So I will more or less be able to cover those that are in black. Those that are in red are not very commonly seen, but they have just make sure that you will cover it also when you are reading. They have very short discussions in your charts, so I will not spend any more time. I had to cut off the slides, some of the slides because it was getting too long. But yeah, you can go over them later. Okay, so let's start. I would like to start with the anatomy of the esophagus, the endoscopic measurements. So you have an average length of 40 centimeters from your incisors to your GE junction. Okay? The GE junction corresponds to the third indentation of the esophagus. Your tracheal bifurcation is found at around 24 centimeters. It's found at around 24 centimeters. And your thoracic inlet is found at around 18 centimeters. The cervical esophagus lies in the neck, bordered superiorly by your hypopharynx and inferiorly by your thoracic inlet, which lies at the level of the sternal notch. So typical endoscopic measurements of the cervical esophagus measured from the incisors are from 15 to less than 20 centimeters. Remember that due to variations in height, sometimes the endoscopic measurements do not automatically correspond to the measurements that you said. So personally, when it comes to clinical practice, I find it more useful to use anatomic landmarks that I see on the CT scan when I need to levelize a tumor, for example, or the lesion of the esophagus. So from the cervical esophagus, like you said, bordered superiorly by the hypopharynx and by the thoracic inlet here. Here. The upper, and then when you talk of an upper thoracic esophageal lesion, it is bordered superiorly by your thoracic inlet and inferiorly by your azygos vein. Your middle thoracic esophagus is bordered superiorly by the lower border of your azygos vein and inferiorly by your inferior pulmonary veins. The lower thoracic esophagus is bordered superiorly by your inferior pulmonary veins, and then down to your okay? So that's where we get your mid-esophageal lesion, upper thoracic esophageal lesion, okay, and the lower esophageal thoracic lesion. Take a look at your pulmonary vein, your azygos vein, and also your trachea, which is there, and then also your thoracic. So that will more or less tell you where your lesion is. And later on, help you decide on which approach you will be using for your another important factor in your esophagus is that it has curves. So your curves, you have two curves in your anteroposterior plane. It starts in the midline at the junction of your oropharynx. It deviates to your left. And as it descends to the thoracic inlet, and then returns to a midline position at about the fifth thoracic vertebra, before once again passing to your left. Okay. Looking at it from the right lateral view, this is the view that you will see when you are doing your Ivor Lewis or your McClone thoracic dissection. What you don't see here is the lung and your inferior pulmonary ligament. Okay? So when you are dissecting in this area, you will see, you will not be able to see these vital structures, so you have to be very careful. So you will need to dissect your inferior pulmonary ligament very carefully, because right under there will be your pulmonary veins, your main stem bronchus, and then your azygos vein is right here. Okay, so what else? So these are your important things. This is your view from your right thoracotomy. If you go back, your view from your left thoracotomy will be able, you will only be able to see this area of your esophagus. Your thoracic, your left thoracic incision will be in your 8th left interspace, and so this is mostly the area you will be able to dissect. Because from this area, you will have your heart covering your esophagus. So that's why your left thoracotomy will only be useful if your lesion is here in the lower esophagus. You won't be able to see it. And your anastomosis has to be somewhere around here and not up, way up near the carotid. Okay, so that is one anatomic consideration that you should remember. Okay, the curves. Also, I forgot to mention, of course, when you are doing your cervical esophagostomy, because of your leftward curve in the cervical esophagus, of course, all of your cervical esophagostomies will be out your left. Let's talk about the cervical esophagus. This is the posterior view of your cervical esophagus. Your upper esophageal sphincter, you have your pharyngeal constrictors over here. Your cricopharyngeus here corresponds to your upper esophageal sphincter. This one is a true anatomic sphincter compared to the lower esophageal sphincter, which is just a physiological sphincter. When the cricopharyngeus muscle relaxes, the upper esophageal sphincter opens, aided by elevation and forward motion of the larynx. Okay? The posterior wall, okay, the posterior wall of your hypopharynx is relatively weak, just above and below the cricopharyngeus muscle. And this is called your Killian triangle. So your Killian triangle comprises the area between the thyropharyngeus and the cricopharyngeus muscles that comprise the Killian. So sabihin natin in France, your Zenger's triangle. Striated muscle, this is an illustration of the transition between your striated muscle, which is found in your upper third of your esophagus, versus your smooth muscle, which is found in 2/3. So it is found near this area by your facial bifurcation. And clinical significance of this is an area of slower transit, slower peristalsis. So long story short, in post-congestion, substances will tend to pool in this area and cause congestion, particularly for strong. Okay, we will discuss that later. Now, blood supply is segmental. You have all of these blood supplies in a very busy slide. What I would like to point out is that una-una, it is segmental, which means that one, if you note your blood supply, your blood vessels are very small, very fine. So it is entirely possible to do your blunt dissection via transhiatal esophagectomy without a lot of blood loss or minimal blood loss. At the same time, when we say segmental, it has levels. So if you dissect in your lower esophagus, so meaning you disrupt your blood supply here, it means that since it is segmental, it will not devascularize your upper and mid esophagus. So that is one of the advantages if you segmental. And you just have to memorize arteries, bronchoesophageal branch, etc. And that you still get from your left gastric artery dito sa baba. Okay? So just go over that later. But what is remember, what is important that in terms of blood supply, it is segmental. In terms of venous drainage, it is also segmental. Okay, so there are some epithelial venous plexi running longitudinally along the whole length of the esophagus, but it is still segmental. These are some of the veins that drains it in the upper esophagus, the thoracic, What I would like to point out are the very prominent veins, like I said earlier, your azygos vein, okay, that can be very easily injured during a transhiatal dissection. Or if you have, for example, a tumor or enlarged lymph nodes in this area, upper, mid-upper esophagus, always look at your CT scan, look for your azygos vein. So, is it safe to do a transhiatal? Do I have to do a transthoracic? Okay. So, second thing to note in this slide is that there is a connection with the portal system. Okay. And if you just recall that, of course, a connection with the portal system means this is what explains the esophageal varices when you have portal hypertension. Now, blood supply segmental, drainage segmental, lymphatics are not segmental. So there is a very unique mucosal lymphatic arrangement of esophagus as compared to the colon. Very, very nice and predictable. The ascending colon drains to the superior mesenteric artery. This one, hindi, no? So because you have a very unique mucosal lymphatic arrangement, you have anastomotic lymphatic capillaries in the lower mucosal layers of the esophagus. So there is a very rich mucosal and submucosal lymphatic network that forms a complex interconnecting network that extends along the entire length of the esophagus. So you have three orders, no? Esophageal, intestinal, and lateral clavicular. What I would like to point out in this slide are, take note of the lymph node stations that are italicized. Okay, so first order, second order, third order, you have left gastric artery connections, you have splenic hilar, common hepatic artery lymph nodes. These are parang ang layo na niyan. These are already intra-abdominal, and yet they are part of the intramucosal lymphatic capillary system. So what does this mean? It is like if you have a tumor that gets into this parang express subway, no? Parang may subway sila of lymphatics. It is very easy for it to spread throughout the entire system. Okay? Add to this that all your lymphatics would drain directly into the thoracic duct, and clinically this would translate into what? A very early widespread dissemination, widespread systemic dissemination of your esophageal carcinoma. And that is why all of these systemic neoadjuvant treatments, perioperative chemotherapy, seems like they are very, very useful because it's very easy for your cancer to spread. And also, clinically, this would mean that there's an incidence of skip metastasis. This is a classic study by Akiyama showing that even those from the upper can still present with lower lymph node spread, so on and so forth. Okay, so always remember, esophagus lymph nodes, longitudinal, possible for skip metastasis. In terms of nerve supply, it's the vagus. Vagus is center stage. Of course, this is parasympathetic. Anatomically speaking, your right recurrent laryngeal nerve can be injured when you are dissecting near this area in front of the subclavian. Your left recurrent laryngeal nerve can be injured when you are dissecting in the lower margin of the aortic part. So you have to be careful whenever you're doing the thoracic dissection. What else? You have okay, vagus also, again, parasympathetic innervation, and you have your Meissner in your lower back, so you already know the function of these things. So these are these are what you have to stress on when you're studying the nerve supply. So vagus and the relation to the nerve. Left anterior, right posterior for vagus. Okay, left anterior, right posterior for vagus. Okay. In terms of diagnostics, I will not dwell too long on these, but just so you know, it's very important that at least you know that the diagnostic armamentarium is available to you. More or less, the one that is most available to us um, are yung mga radiographic studies, the contrast studies, barium swallow, thin barium swallow, water-soluble contrast swallow. If you do it with your fluoroscopy, you'll be able to see a dynamic image. What else? Your manometry. Your manometry is available, I think, not readily available for all of us, but in English it is available. It is a gold standard in some of the motor disorders. So if ever you have patients teaching that it is available. But personally, a lot of the diagnostics that I have seen are based on contrast radiography. Of course, CT scan for readily available already, and also EUS. EUS has become very popular. So EUS, just going through it rather quickly, you are able to appreciate the different layers of your esophagus. So it shows as a white, black, white, black, white, so alternating image. So your superficial mucosa is the first white, so it is hyperechoic, superficial mucosa. Your mucosa is hypoechoic. Your submucosa, what earlier we said, nandiyan yung lymphatics natin, submucosa. It is T1B, it is hyperechoic. Muscularis propria is white again, it is hypoechoic. Adventitia is hyperechoic. So audio is fine? Okay lang pa. Narinig natin. So, yun. So in this example, for example, in this image, the lesion is found at the 12 o'clock position, and it has violated the full thickness of the esophagus. Okay, so this T-staging, very important. It will affect your decision if you can do an endoscopic mucosal resection, endoscopic submucosal resection, or to know really the T-stage, because as we will find out later on, your T-stage will dictate whether you will start with
Dr. Marjorie Mahinay, please contact the next one.
So if there's a problem, you can just tell me. GERD. GERD, I'd like to again go to the anatomic barriers to reflux. It is a segment of your intra-abdominal esophagus. You have your flap valve apparatus, particularly created by your angle fist, and you have a competent lower esophageal sphincter, again, which is a physiologic sphincter. How do I explain this? I will explain further with this article. And by the way, for all of us who are always asked about physics concepts during our conferences, I highly recommend that you download this article. It covers a lot of the classic questions of Laplace, in obstruction, pancreatic pseudocysts. In the pancreatic pseudocysts, why doesn't the food go to the cyst when you do assisted gastrostomy? But hindi siya lumalabas doon. They will explain it in this. But for today, I would like to use the Quadrini's law, pronunciation, to try to explain the concept of reflux. So if we look at the law, this can be applied to any fluid moving through your tubular lumen. In this case, in this paragraph, they are using the example of the blood flow. Okay? So basically, you just look at the equation. It just says that if you want to have a high flow rate, it is directly proportionate to your pressure difference between the two areas. So high pressure, low pressure, low pressure, pagka masyadong tinutulak ng high pressure. The radius, the length, the width of your opening, the radius, you have a higher flow, so they are directly proportionate. And they are inversely proportionate to the viscosity of your fluid. It's too sticky, it will not flow. And to the length of 2. Okay? So, ganon. So, inversely proportionate to the left. When we talk of blood flow, syempre, gusto natin magandang flow. But for this example, we will be using the Clausius law for reflux. And for reflux, for treating gastroesophageal reflux, we do not want high flow. Gusto natin tumigil yung backflow. So therefore, if whatever procedure that we have to do, kailangan bumaba ito, so kailangan tumaas yung length, bumaba yung radius, bumaba yung pressure difference. How do you memorize it? How do you remember it? So there's an experiment, no? Imagine you have a soft straw. Yung straw that you are using kapag when you buy soft drinks, lambot ng straw nila. So if you have a soft straw, and if you dip it very deeply into a very deep glass of water, and you try to suck on the straw, the straw will collapse as it is sucked. And this is because your hydrostatic pressure compresses the straw from all directions. Kasi ang haba ng pinasok mong straw sa baba. So you give the hydrostatic pressure more chance to press on it. Now, if you pull back your straw, maikli na lang siya, you will find that it is much easier to get the water, to drink water from the straw, because the hydrostatic pressure, the pressure from the water, is not enough to collapse the straw, and therefore the atmospheric pressure on the surface of the water pushes up the water in the straw. So in effect, you try to imagine this as your intra-abdominal esophagus. So the more intra-abdominal esophagus there is, the more esophagus that can be pressed on to close your esophageal junction. Right? So length, okay? Another thing to help you memorize, no? When you are full, diba? We are always telling our patients, do not lie down when you are full, because you have a very short lower esophageal sphincter when you are full, when you are distended, and then your food can more easily reflux because the length of your lower esophageal sphincter is shorter. Okay? How about in terms of obesity? When you have obesity, two things happen. The fat deposition around the esophagus changes, no? Mas madami. And ang nangyayari, your incisura becomes less acute, no? Dahil napupunin ng taba. So, it opens up, opening you up to reflux. Your intra-abdominal pressure on your stomach, on the other hand, is also greater, no? So, may tumutulak sa stomach mismo, no? To push back the contents, and thus it promotes the reverse flow of your stomach contents. And this explains why weight loss, with surgery sometimes, is part of, or can be part of GERD treatment, as this paper demonstrates. So always, again, Clausius, direct proportion to blood flow, to volume flow, pressure difference. If you have a wider radius, reflux. If you have a greater length of intra-abdominal esophagus, anti-reflux. Okay. Well, you know this. So this is basically from the paper. Let's get that. So indications for surgical treatment for GERD. This is from Cameron. You have failed medical management. Of course, you start off with PPI. There's patient preference if you have GERD complications already. If you have a contraindication to PPI therapy, osteoporosis, because studies have shown that PPI, taking too much, chronic PPI intake causes decreased calcium absorption, so osteoporosis. So you can offer that. Patients with who are candidates for lung transplant with gastroesophageal reflux, medical complications attributable to a large hiatal hernia, and atypical symptoms of reflux documented on 24-hour pH monitoring. In Schwartz, they add this one. If you are a younger patient unwilling to take lifelong medication, you will develop the progression anyway, so might as well get it now. They also presented a cost advantage over medical therapy if you give it in patients younger than 49 years old. It's more costly. So what are their primary anti-reflux repairs? Number one, the original OG, Nissen. It is a 360-degree wrap of 4 to 5 cm of your esophagus. In the classic one, you do not divide your short gastrics. This was later modified to a short and floppy Nissen. You use your gastric fundus again. You use a Bougie 60 French, 1 to 2 centimeters length only, and you divide the short gastric artery. So you have a more mobilized fundus. The most commonly used are Toupet, 270 degree posterior around the distal 4 centimeter esophagus. So posterior to 70 degree, most utilized Toupet. Anterior partial, if it is an anterior 180 to 200 degree fundoplication, it is indoor. So used primarily in association with lap hellers or achalasia. I will show later on bakit anterior when you're doing a lap heller. A hill, this is unique in that you are restoring your flap valve apparatus. So meaning the normal anatomic structures that are there that was worn down, you will try to restore it via your suturing, no? So your posterior attachments, your collar sling musculature, the muscles that are around the lower esophageal sphincter, and the angle of his. So that is your hill. Your Belsey Mark IV, this is unique in that this is the one that is transthoracic. It is a 270 degree anterior. Very limited use now. It is most relegated now to just the hostile abdomen. If you have an extremely large hiatal hernia in which you really have to go to the thorax, or if you have a short esophagus. So let's see, you are not here. If you can try to identify each one of these things. Okay, I will not hear you. Okay? So what is this first one? Okay, so you have a 360 degree wrap, balot na balot, but you maintain your short gastric. So this is your classic Nissen. This one, 360 degree wrap pa rin, balot na balot, but you cut your short gastric, and ang hindi lang nasama dito yung length, no? Dapat kasi 1 to 2, it should be shorter distance. This is your modification of your Nissens, your short and floppy. This is your most commonly done. Okay, it is only a 270 degree wrap, no? So kita mo pa rin yung esophagus. You mobilize also yung short gastrics. This is your Toupet fundoplication. This one is anteriorly placed. So this is anteriorly placed. So parang may tinatakpan ka dyan. Particularly, syempre, in our case, yung myotomy mo. So this is your door anterior fundoplication. Here, you are restoring your flap valve apparatus. Okay, you are reconnecting the posterior attachments. You are making the angle of his. You are making the angle of his, closing it, making it more acute. This is your hill fundoplication. And finally, this is a view from within your thoracotomy. As you can see your pericardium, your esophagus. Your suturing here is from a superior to inferior direction. And as you can see, when you close that, it will thicken up the muscle, no? Your plication. And also you will be biting to the diaphragm. So this is your Belsey mark for fundoplication. Okay? So there's a part in the book that says esophageal their call is gastroplasty. Kasi remember, sabi ni Doc, you said, we want length, no? We want length. We want more length. So one procedure that can be done to do to achieve this is the call is gastroplasty. Okay? So basically what happens here is you use a stapler to divide the cardia, your upper stomach, and then use that as your wrap. No? Ipit mo dito. The problem with this is really controversial in that, number one, people are questioning, is there really such a thing as a shortened esophagus? No? Whenever you do your dissection, you will find that your esophagus, you can get some length there if you dissect off the attachments within the thorax. Mahahapak mo yun. Okay? So most of the time, there isn't really a shortened esophagus. Second problem is, remember, this area is acid secreting, and now it is non-motile, and you are wrapping it around fundoplication. So wouldn't this be counterproductive in your anti-reflux surgery? Meron kang segment na may acid producing, so that could also exacerbate your esophagitis. So these are some of the problems with cholestatic history. So based on the book, we limit really the indication for your colis to when it is really impossible to mobilize your esophagus. And when is that? Patient maybe had previous radiation, okay? Or patient already had a previous anti-reflux surgery, so you will need extra length. And then there is already, you are going against fibrosis. Okay, so that is your colis gastroplasty. Now, future plans or emerging surgical therapies, our gold standard are still yung surgical fundoplication that I have mentioned earlier. But there are new emerging therapies that are endoscopic. The first one would be you will be doing a transoral incisionless fundoplication via your esophagus device. And it creates an anterior partial fundoplication with an H-placed, an H-shaped fastener, So nandito, it's like you're stapling a new angle of this. Okay. Another possible endoscopic treatment is your STEPA. So this is an endoscopic device that induces heat-mediated remodeling of the lower esophageal sphincter via radiofrequency energy. So you are ablating this area, and it will tighten up. You will have some degree of stricture or fibrosis there. Similar to that is your anti-reflux mucosectomy or mucosa ablation, which is called ARMS or ARMA by the Japanese Inoue. So that you recreate the flap valve by ablating the surrounding mucosa. So this is during the procedure, and then later on follow-up it becomes tighter. Okay, very good. There are significant differences based on their data. So very, very promising in terms of decreasing your symptoms for reflux. In terms of laparoscopic surgery, you have the LINX device. So instead of doing all of these wraps, you just get this titanium link that has magnets in it, and that will create a one-way valve. Pagpasok ng tube, it will close immediately. So it is contraindicated in the following, and there's a problem if you have allergies, and if you may require future MRIs. The problem is there is a chance of a possible erosion, but still the treatment, the outcomes are very promising, and if there's a problem with it, you can replace it. Okay? But again, still the gold standard is your operative.
Pedia resident to emergency room. Pedia resident to emergency room.
So you need more long-term. But these are the promising options. We cannot talk of GERD without talking about Barrett. So you know about metaplasia. So just look for the following keywords: goblet cells, pink, salmon color, squamous, columnar. So, and very important with this is the major risk factor for esophageal adenocarcinoma. So when you have your Barrett's, your management goal is to treat the underlying cause, which is GERD. You prevent the progression of the Barrett's if it is still low-grade dysplasia, and you will treat the dysplastic Barrett's before it transforms into adenocarcinoma. This is the algorithm that is found in, I think this is in Cameron also. So if you take a look, you can look at it later on, yung sa low-grade dysplasia nagkakatalo yung ating management. If you have no dysplasia, you can just consider repeating your EGD. Of course, you'll be doing your biopsy. You can just do surveillance. If there's dysplasia, you can do long-term wound management with PPI or anti-reflux surgery, right, to prevent progression. For high-grade dysplasia,
Pwede resident to
that's a
emergency
different
room.
matter altogether.
Pwede
We'll discuss
resident
that
to
later.
emergency room.
High-grade dysplasia, this is it. So more or less, you will be starting to do your ablation. Okay, so esophageectomy is also an option. If you have visible lesion already, you could do an endoscopic mucosal
Gonzaga,
resection
punta ka ng
already.
spine.
No, i-impart ka na dito.
Dr. Gonzaga,
You are already
punta ka
bordering
ng
towards
spine.
the esophageal cancer guidelines. If you have a stage 1A malignancy, yan, you go on. So, yun yung okay, I also looked at the American College of Gastroenterology guidelines. The difference there is they treat it differently with regards to the gross appearance. No? Sa kanila, as long as there's nodular bias already, you can go straight and stage it. No? Go to endoscopic mucosal resection. Look for your dysplasia. No? But apart from that, it's all quite similar. Okay, this is your surveillance. Okay, so screenshot. So take a look at it. Basta, always remember, if you have Barrett's, your options are you will need to do representative biopsies, treat according to degree of dysplasia, and then follow up.
Dr. Mahinay, punta ka ng spine. Dr. Mahinay,
Hiatal
punta
hernia
ka
is
ng
also
spine.
related. So hiatal hernia, in general, it is your stomach or intra-abdominal organs permeating to your thorax. You have different types. Your one is your sliding, very common. Your two, rolling. Your three is your combined. Your four is when you have other organs that permeates as well. As you can see, this can be this is also related to your volvulus, your gastric volvulus. You have your hiatal hernia, and this is what makes your hiatal hernia so dangerous. That is, if you have not just the obstruction, but the risk for perforation, necrosis. Your giant paraesophageal hernias, at least 50% is in the mediastinum, or the hernia measures at least 6 centimeters on endoscopy. Also, the term paraesophageal hernia refers to the two. So indications for correction if you are symptomatic, okay? Without prohibitive operative risk, you are a good surgical candidate, should be corrected surgically. These are the symptoms, okay? More or less, you are familiar with them. Conservative management, if you are elderly, minimal symptoms, so you may opt for conservative management. However, they really recommend, so far in what I've read, as long as even in asymptomatic patients, but then if it is documented incidentally, if you are in otherwise excellent health, they recommend to go ahead with the procedure. Okay, diagnosis via barium esophagogram, upper endoscopy, abdominal and chest CT would give you more details. No, if you have a type 4 hernia, so you will see what organs are in your thorax. Your manometry will be able to help you in documenting the peristalsis of your esophagus, and it will guide the conduct of your anti-reflux surgery. Your pH monitoring study might not change your management, whichever your result is. You will still need to do your anti-reflux surgery here. Okay. So the surgical treatment, so it's either lap or open, but the basic principles are the same. Reduce your abdominal contents into the abdomen, excise your sac, return your G junction into the abdomen. Remember, then mobilize your intrathoracic esophagus to ensure that 2 to 3 cm of tension-free intra-abdominal esophagus is available, and you repair your diaphragmatic hernia defect in the esophageal hiatus. Do you have to use mesh? If you look at Schwartz and if you look at in Cameron, they have differing opinions. In Schwartz, they because there's a particularly high recurrence rate, um, they recommend mesh. However, on the same breath, the same sentence, you must be careful because there's a potential risk for esophageal or gastric corrosion, and in the worst cases, an aortic erosion. And on top of that, mesh infection. And then after that, they proceed to the benefits of using a biological mesh. This seems to be a lot less reactive, but this is more expensive. On the other hand, the randomized controlled study that supported biological mesh failed to demonstrate superiority over suture alone after 5 years of rigorous follow. So the conclusion in Cameron by Schlockman and Tati said that based on the current evidence in our experience, the use of mesh not routinely recommended and should be reserved for patients between tension-free pleural repair cannot be achieved. Your anti-reflux procedure, no, in the citation, most advocate the routine addition of an anti-reflux procedure following
Miss May
repair.
Gutierrez, contact local 250.
Okay,
Miss
motility
May Gutierrez,
disorders.
contact local
So we will start
250.
from the very top. So in your pharynx and upper esophagus, patients may present with the transit dysphagia. So ano yung transit dysphagia? You will sense an inadequate oropharyngeal bolus transport, inability to pressurize the pharynx, inability to elevate the larynx, discoordination of the pharyngeal contraction and pharyngeal relaxation, and decreased compliance of the pharyngoesophageal segment secondary to neuromuscular disease. And in terms of bucket, what is the cause? Always you think of whether it's congenital or it is neurologic. Na stroke ba siya? Okay? Does the patient have brainstem tumors, polio, multiple sclerosis, Parkinson's? Okay, all of these things. Other peripheral diseases, myasthenia gravis, dermatomyositis, dystrophy, and of note here, no, they consider extrinsic compression via a thyromegaly a possible cause. So look also for that, particularly in the Philippines, because sa atin yung mga okay. We have to discuss traction and torsion diverticulum at this point. So your traction diverticulum, this is mostly from your inflammatory disorders that's causing an adhesion on the exterior of the esophagus, pulling the esophagus, traction, causing weakening or a diverticulum, versus a pulsion diverticulum. This is the one caused by your motor disorders. So if you have a hypertensive here, hypopharyngeus area, your bolus has nowhere to go. It will push out of the lumen, push out, propulsion, because hindi dahil pulsion, may pull, mali yun. So propulsion is push, causing your pulsion diverticulum. One thing of note, no, when you are starting to develop this diverticulum and you have a tight epipharyngeal area here, you will find that the patient will have a temporary relief of dysphagia because the diverticulum becomes a receptacle for ingested food. Okay? Zenker's, more or less, I've discussed the pathophysiology. So there's histologic evidence of restrictive myopathy in your cryptopharyngeus muscle. So parang kakalayo siya pero mataas. Okay? Symptoms, okay, you know your symptoms. So may bara pa din sa taas. So we already talked about that. You diagnose it by your barium swallow. Endoscopy may be difficult and potentially dangerous. Okay, so you might perforate the diverticulum. So you treat it via one treatment is your open cryptopharyngeal myotomy. You divide 1 to 2 cm inferior to superior muscle of the pharynx. Cephalad, so luluwagan mo yung sa pharynx. Then caudad, you divide the cryptopharyngeal muscle and the cervical esophagus to a length of 4 to 5 centimeters. Same as, very similar to the achalasia, no? You have a long myotomy, diba? Hindi lang sapat that you cut the top, it has to be long. Okay? There are also minimally invasive options for that, like reticulopexy, diverticulectomy, so you can look at it. Okay? Moving further down the achalasia, this is the most common primary esophageal disorders. Autoimmune response in a genetically susceptible individual triggered by an infection. This could be one of the main causes. Diagnosed via manometry, but like I said earlier, kadalasan yan we will see it via the symptoms and the characteristic birds with appearance in contrast to the in your scope, you will see dilated or tortuous esophagus, food, persistent scope, and manometry, like I said earlier, it's the gold standard for diagnosis of achalasia. You have types based on your manometry findings. Take note that they differentiate between not just the tone of your achalasia, but also the remaining peristaltic contractions of your esophagus. Okay, so type 2, you have an absent peristaltic contraction. Type 3, you have impaired relaxation with premature spastic contractions. But we don't have that in most centers, so there's a clinical score, no? Your Eckhart score. You take a look at your dysphagia, regurgitation, your intestinal pain, weight loss. If you do this is a way of monitoring the success of your treatment, no? So you stage your patient. If you have a score of 3 or lower after the therapeutic intervention, that's good. There's treatment success. But the limitation of the score is, if you take note, on 3 or lower is if your patient still has dysphagia every meal, then you would think, successful ba ang treatment ko? Tapos wala yung lahat ng iba. So that is the limitation of the Eckhart score. But yeah, this is your clinical scoring for achalasia treatment. Okay? Medical treatment, nitrites, may mga medical. For those who can't tolerate more invasive therapies, poor side effects are your problem, poor tolerance, poor absorption because these are oral meds. Endoscopic treatments, you have your Botox injection. However, the effect is transient, and later on, the effect would be a lot less efficacious in later injections. Okay, so these are for those who are not candidates for surgery or for dilatation. You can also do a pneumatic dilatation. Problem is your recurrence. Okay, so and also check out for your perforation. POEM, on the other hand, this is very promising. This is an endoscopically done myotomy. So the strength of the entire procedure is basically we're doing what is recommended, a myotomy, but it is minimally invasive. Okay, so it is feasible and safe, and short-term outcomes are very good, due to the 90%. Of course, we will need more studies for long-term efficacy and symptoms. So this is what we will basically do. We assess your esophagogastric submucosal space. Okay? We do a proximal to distal myotomy. So this is your incision to the mucosa. You will enter it, and this is what you will see. This area is the circular muscular layer. So you will be cutting through that, and then later on, once you reach your cardia, you're done, and then you'll be closing the mucosa with your tips. Surgical treatment. So gold standard, lap Heller's myotomy with partial implantation. When you are doing your procedure, watch out for aspiration during anesthesia. Get your endoscopist ready to do intraoperative endoscopy. They are very useful in evacuating any remnant food there, doing lavage, irrigation, and intraoperative assessment of the repair. If it is too tight or if it is too loose. Your myotomy has to be 5 cm above G junction, up to 2.5 below onto the cardia. So it is a long myotomy, adequate myotomy. Be careful of the thin muscular wall at the transition of the distal esophagus to your GE junction, because you can have a possible perforation. Here is the procedure demonstrated, doing it laparoscopically. And take note here, uh, is something that we discussed earlier, no? So this is your door, your anterior fundoplication. Very convenient. You have an anterior defect, of course, no? And then your first stitch of your door is 2 cm from the angle of this to the right edge of your myotoma. Okay, so this apical stitch incorporates the diaphragm and the cut edge of the muscle, and this stitch would accentuate your angle of this. Okay, so the frontula. Okay, transthoracic, abdominal approach is not visible, and then here you will use your bell seat. Don't forget to leave a CPT. Okay, very advanced appellation. You have a dilated, very big, very widened esophagus already. And esophageectomy is a possible option. But so far with Lapp-Hellers, there has been 90% of patients that have improved. So this esophageectomy is your last resort. Okay? Carcinoma. In the past, it's always squamous cell because you histopathology above. But with increased incidence of Barrett's, particularly in the West, sa atin it's still more in Asia, it's still more squamous cell. But in the West, the Barrett's is giving rise to a greater number of adenocarcinoma. Esophageal carcinoma is more common in males, 2 to 3 times for females, and these are your risk factors. Your reflux disease, obesity. So take note of all of these things. Hindi mahalaga dito ito, yung pinakain natin, carcinomas. So there, techniques. Okay, so before we move further, in terms of lesions in the GE junction. So this is significant not just for the esophagus, especially for the stomach. So you have to identify whether it's a CWART 1, 2, or 3. CWART 1 is between 1 and 5 cm above the GE junction. CWART 2, 1 cm above and 2 cm below the GE junction. CWART 3 is beyond that, 5 cm. So if you have CWART 1 and 2, treat it as esophageal. You have CWART 2, treat it as gastric. The algorithm for your squamous cell carcinoma, this is in NCCN. I just want to stress that for T1A, you can do your endoscopic mucosal dissection. Very rarely done among us because the obstruction presents rather low. Okay. Again, squamous cell carcinoma for T2, high risk lesion. The NCCN recommends preoperative chemo-RT with neoadjuvant starting at T2 for non-surgical. Ito yung wala sa adenocarcinoma, the definitive chemoradiation for if it is in the cervical esophagus. So, malabo naman mag-esophageal cervical na adeno. It's here. No? So there's an option for definitive chemoradiation. Okay. And then unresectability, it's either chemotherapy alone or there's sedation of the peripheral vessels. You will see that in your CT scan, and you know why that's in your. So I'd like to stress in this slide, if you can see you check your response assessment, they now recognize the FDG PET, as the preferred imaging study. In other NCCN guidance, napapansin yung PET is always an adjunct, and they have found that in esophagus it's rather useful because esophageal carcinoma takes up the FDG rather actively. So very useful, considering that you will also be subjecting your patient to rather morbid procedure. So magandang gawa. If not, if it's not available, you do your CT scan. Okay. Adenocarcinoma, very similar again. T1A, you can do an endoscopic or resection, or in select cases esophageectomy. Pre-op chemoradiation still, okay, for patients who are operable, it is preferred starting T2 with high risk lesion. High risk lesions, so ibig sabihin, you can still do outright if it's low risk, right? So when you see Okay, listen. Let's look over that later. Very important that we discuss the cross trial because these are basically the level 1 evidence that brought us those guidelines. What the cross trial? Uh, the researchers compared resectable cases of esophageal malignancies, surgery alone versus the weekly carboplatin paclitaxel, the carbopaclin with radiation for 5 weeks. Outcomes showed pathologic complete response in 29% of patients, 23% in adenocarcinoma, 49% in squamous cell, R0 resection in 92 patients in those in the experimental group, whereas only 69% in the surgery-only group. Mortality is the same. In terms of overall survival benefit, the median follow-up was into 4.1 months, and the survival was 48.6 months versus 24 months. Dodobling buhay nila if you give neoadjuvant. Okay? Thanks. So that's it. So that's cross trial. Your FLOT4 trial is a perioperative chemotherapy. So this has become also one of the useful techniques for treating esophageal malignancies. So they give perioperative FLOT, okay, for 8 cycles versus ECF, yung classic na MAGIC, okay? And here they have found that in the FLOT regimen you have a 50-month versus just a 35-month in your old ECF regimen. But what we want to know is what to compare is what's better, Chemorad or in FLOT. No? So there is currently a clinical trial that will be completed on 2023 that is comparing both of that. So this is called the ESOPEC trial. Watch out for that. And then there's also another one that is comparing docetaxel plus CAPOX versus docetaxel CAPOX plus radiation versus your cross regimen. So pinaglaban yung iba-ibang regimen. Okay, so these are things, they will come out in 2027. Surgical approaches, alam niyo na to, Ivor Lewis, thoracotomy, Macron, Field. You now have the benefit of minimally invasive thoracic surgery. So these are options if your center has expertise. Your transhiatal has, this is very useful. No? You just do a laparotomy with a cervical anastomy. So you can remove any thoracic tumor in any location, in mid, upper, and lower, without having to do a thoracic thoracotomy. But you will have to always check if you have large middle esophageal tumors adjacent to the trachea, or if you have large subcarinal nodes. You have to check in the CT scan because this would be too dangerous for you. In terms of the outcomes, the proponents of your transhiatal would always say that they have equivalent outcomes versus your thoracic esophagectomies, but you have less lymph node retrieval. But you cannot argue with more or less similar outcomes. So transhiatal is still a very good option. Okay, and you have your left transthoracic or thoracoabdominal approach with anastomosis in the chest or neck, or iliac incision. Remember, if it is lower, yan lang ang makikita mo. If you do your anastomosis in your neck, there is a higher chance of leak, but it is much less lethal. Because remember that if you do your thoracic anastomosis, there is less chance of leak, but the consequences are dire if you leak intestinals. Okay? Your conduits, gastric wall, and your jejunum, your lymph node dissection, if without induction from RT, at least 15 lymph nodes should be removed. These are the complications. Okay? Majority are respiratory, and that's why the benefit of the transhiatal is you have better short-term outcomes. Okay? So largely respiratory, very important that you select to properly select your patients if you are going to choose to do a thoracic esophageal dilute and anastomosis perforation. Very quickly, what I'd like you to remember in perforation, so more or less you know how to diagnose it, diba? Water soluble, alam mo na yan. Presentation, patient can present with signs of sepsis, etc. Pneumomediastinum. Buttress, when you do a repair, particularly when your esophagus is friable, you can always use your tissue buttresses, using your strap muscles, your SCM, your diaphragm, your intercostal muscle, or your pleura. In trauma, yun, madalas yung ginagawa. Minimally invasive, you can do stenting if it's a very limited perforation. And if you have really through and through perforation in the chest, a VATS is an option after 1 to 2 days for the treatment. But you have to make sure that it is okay. So again, patient selected. This is an illustration of the diaphragmatic patch. Costic injury. Okay, this is they like asking questions about costic injury from Shackelford. So it could difference between acid and alkali, liquefactive necrosis, acid coagulated necrosis, and therefore with coagulated necrosis, your lesions are a lot less severe, no? Because your coagulated necrosis forms an eschar, a protective eschar, and also if there's an instant burning sensation when you taste your acid. However, there is a tendency for it to cause pyloric spasm. So there is gastric retention and possible gastric friction in the future. Alkali, susunodin talaga sa operation. So when you have a patient, you take a look at the pH of the substance. How viscous was it? Your concentration. In your accidental ingestions, you will tend to have lesser ingestion as compared to your suicidal ingestion. How long was the contact time? Does the patient have comorbidity? So these are the phases of your alkali ingestion. What I would like to highlight, this is in your book, what I would like to highlight here is what causes, there is a thrombosis of your vasculature, and this causes your weakening or your evolution of your injury as time goes by. So lalong nabibulok ako ng mga agad. There is an ulcerative phase, and this area in this time, the esophagus is very raw, okay, and very weak. So this is the area, this is the time when the esophagus is at its weakest, no? Kung mapasok pa lang yung fiber days. And then, ultimately in the future, it will scar. Okay? So you will need to have treatment for later on for scarring, and the consequences of that, if you have time pasyente, you will need to have a plan for treating. Okay? In the emergency room, similar to trauma, EDCs, stridor, you need to intubate, establish IV access, black or gray slot in the oral mucosa. Does the patient have neck crepitus? Does the patient have a surgical abdomen already? Check your ABGs, check your blood chem, and very useful, the chest and abdominal x-rays to show you pneumothorax, pneumomediastinum, pneumoperitoneum. Okay. Contrast, hindi naman daw kailangan, baka magkakalat sa loob. Endoscopic assessment. Very important that you grade. You will decide your management based on your grading. Take note that your necrosis, I would like to point out, your necrosis starts at grade 3. Okay? So grade 2 tissue necrosis. More or less, the grade 1 would heal without, this is mere erythema. No? This would heal without incident. 2A also, medyo similar sa yung clinical course. Your 2B, this one more or less, sabi nila this would heal by stricturing. So this is the middle ground, which is stricturing. Your 3rd degree with your full thickness necrosis, this is the one that may require immediate resection. Okay? So you admit the patient, resuscitate, administer broad spectrum antibiotics against gram-positive and anaerobes. So sometimes others do not give it, but most would give because the GI has a lot of bacteria and viruses in the mouth. Do not induce vomiting, do not neutralize, because if you give neutralizing agent, there will be an exothermic reaction and you will have more thermal damage. Steroids, question mark. In the past, there are some studies that say, oh, it could cause less stenosis, you know? But there are higher GI hemorrhage. However, systematic reviews have shown that there's no clear advantage. So be prudent. Don't just give steroids. Okay. Antacids, H2 blockers, PPI, yes, or because you want to reduce GE reflux. Do we do early stenting so that we prevent contraction? So according to Shackelford, you have the risks of migration, you have bleeding, tissue injury. Remember that when you put it early, you will be subjecting the patient to a foreign body during the weakest area or the weakest time of his operation. And therefore, there's a high risk of perforation. And they say that it is most likely that, you know, your initial stage, your progression to stricture is already determined. So it will just inevitably reveal itself. Okay. For thickness injury. Okay, for this one. Combination of a systemic disturbance and hemodynamic instability and extensive injury, OR. That's that. There's a study from Taiwan that said that in their series of patients, those that were acidotic were the ones that required surgery, and those that were not, they were able to manage conservatively. So I haven't seen a grade 3 na. Most likely kasi in grade 2 it will become surgical. So what do you do if ever you have a very, so this is a very limited grade 3, 3A pa for this one area, and very stable in patient, very strong patient. What do you do? Because you want to catch it early. If ever evolving into something worse, you will have to be very aggressive to reduce your morbidity and mortality. So what is one option that is in Shackelford? You can do a laparoscopy. You assess the serosa. If it is necrotic, then you do an esophagectomy with your vein stripper, a total gastrectomy, a cervical esophagostomy, and you just put in feed-in-the-veins. You don't do your reconstruction. You just get the patient out of, get the sepsis. Okay. In PGH, I'd like to show you this is a study that is published by gastroenterologists. So more or less, they reflect the same algorithm as what I mentioned. So you can download this one. The problem is these are done by GI, so they cut short sa surgery. So wala kasing sinabi na siya. So just recall what I said earlier. In Schwartz, I would like to point out that in case you're examining, gets your question from Schwartz, at least you're prepared, because there is some difference in the chapter. In terms of treatment, they have a very low threshold for exploratory. At second degree, they already do an exploration in Schwartz, and you check the viability of the esophagus and stomach. So if the question brings out, kung napansin niyo nasa multiple choice question, nagkaroon ng posterior wall biopsy, diba? And parang early exploratory laparotomy, maybe the examiner got it from Schwartz. So also in Schwartz, there's also an illustration there of your intraluminal esophageal stent that is not recommended in other source. So just be aware of that and then choose accordingly. There is also the option of doing a second look operation after 36 hours if there's a questionable viability. In the previous source, this can be replaced with your, of course, pwede naman itong laparoscopic. So you can also do that. And it is only when you have a full thickness necrosis where you will do the esophagogastric dissection, cervical esophagostomy, jugular dissection, adjacent wall. Okay. So that is also stomach and lang. I will skip the bezoars, foreign bodies, the benign neoplasms. Let's just go over to your peptic ulcer and your malignancy. This is your anatomy. Try to remember here in terms of the blood supply. It is very rich. You have 4 main blood supplies there. your gastric ectopic, your short gastric, and your left and right gastric. Okay, your it says in the book that your stomach, your graft can survive with just one. But if you have two, as in your gastric pull-up, that's good. Okay, so there's a very rich again submucosal plexus, very similar to the esophagus. Okay. Veins, very similar. Again,
Dito yung
okay.
vehicle to
Acid
emergency room.
secretion, it's just
Dito
moves
yung
very
vehicle
fast.
to emergency room.
You have all of your cells. Let's just focus on your parietal cells because this is the one that produces hydrochloric acid, intrinsic factor, and bicarb. Okay, this is your parietal cell. Okay, physiology na lang mabilis. Remember that almost all of the parietal cells are in the proximal 2/3 of your stomach, and only a few are found in the gastric antral cell. Proximal 2/3 acid, yun ang tatandaan ninyo. What causes increased acid production? Gastrin, acetylcholine, which is from your parasympathetic, your histamine, and what reduces your gastric acid secretion? Somatostatin. So, cleotide, yan. H2 receptor blocker, diba? Ganyan. Okay. Pagotomy, ito yan. Then sa gastric, you have a gastrinome source of gastric. And this is your proton pump, the final common factor. Your proton pump, and this is where your proton pump inhibitor works. H. pylori, as you know, I will not dwell too much on this, but H. pylori is one of the main causes of your peptic ulcer disease. Up to 90% in duodenal, and 70% positive in gastric ulcer. You have several tests to check for it. We will do a breath test, very convenient, 8 to the 90% sensitivity specificity. You can use this for your post-treatment follow-up. Okay? Of course, your biopsies. There's a subset of patients wherein you might recommend H. pylori treatment. If patients who are PPI, non-smoking, non-insect consuming, with unexplained disabilities. Peptic ulcer disease, you have focal defects, so you already know this. Bumaba na siya in recent years. You have the modified Johnson classification based on the location and based on whether it is acid producing. Okay, so 2 and 3 ang acid producing kasi body of the stomach. Remember? 2 and 3. Okay, and your P. pylori. Yan ang acid producing. Okay, 5 yung sa NSAID. Ito, I have a professor who likes asking this all the time. What if you have a type 4? What can you do? No? Type 4 is here, no? Pressure curve, mataas. So, the option is Ascendis procedure or Poche procedure. Pag mataas, Ascendis procedure. Ascendis is a subtotal gastrectomy and a Y esophagogastrogastrectomy. The Poche, you will anastomosis with your bilirubin. Okay, most common complication ito yung nakikita natin. Most common, bleeding, perforation, and obstruction. In terms of individual surgery, yung nakauso sa ating perforation. So, don't ever forget that gastric cancer must always be considered in patients with gastric ulcer or gastric outlet obstruction. There is a table in the book. Diyan na lang, balikan nyo. Most of our cases are in the emergency setting. So, usually in shock or moribund. So, kadalasan hindi tayo makakapag-definitive procedure. But in case tinanong kayo na stable yung pasyente, just pick yung definitive procedure here. In terms of techniques, if you have bleeding, how to access your bleeding duodenal, you do an anterior longitudinal duodenotomy until your pylorus with the stomach. You ligate your gastroduodenal artery by a 3-point super ligation. Figure 8 in the top and the bottom, the U-stitch underneath to cover your transverse pancreatic branches. So 3 points. Perforation with Williams patch or your Selling-Jones. Don't forget to get a biopsy from your gastric ulcers. Duodenal, do we need to? No, we don't. Virtually 0% lumalabas sa duodenal outcome. This is your, sabi natin kanina, baka may elective na makaka-benefit from it. Stable patient. This is your highly selective vagotomy. As you can see, you are vagot. This works because you are vagotomizing the proximal two-thirds, which, as you can remember, is really the bulk of your acid producing cells are here. So you do this and you preserve at least the function of your thyroid. So highly selective vagot. Anti-H. pylori regimens, you can check that in your book. Very important in the clinics that you get your local sensitivity studies, because hindi lahat ng nandito are sensitive to our setting. Like in this study from St. Luke. Very important. Let's go with adenocarcinoma of the stomach. You will be running through the gastric cancer guidelines of your the Japanese gastric cancer guideline. And this will help us first in determining what will be my margin. Second, what lymph node dissection will I be needing to do. So in getting the margin, we look at the Borman classification that is determined on endoscopy. So type 1 and type 2, you just need 3 centimeter margin. If you have the more infiltrative growth patterns, type 3 and type 4, you need a 5 centimeter proximal margin. If this is not familiar to us, parang doc, parang hindi ginagamit namin, parang hindi ginagamit ng endoscopy ito. Parang hindi ginagamit sa amin ito. So, it is because mostly in the Philippines, we have very advanced cancer. Kadalasan yun is 4 or 3. So, no point always 5 centimeters. But know that if you have a T1 lesion, you can get away with it using margin. That's in early gastric cancer. When you define early versus advanced gastric cancer, if you go to Conference, early gastric cancer invades no deeper than the mucosa, irrespective of nodal stuff. Okay? When we talk of advanced gastric cancer, this is T1 disease, advanced gastric cancer, T2 disease. So sometimes when you attend conferences abroad, they will say advanced gastric cancer, tapos advanced na ba yun? Parang ang liit, di ba? Yung makikita natin sa Pilipinas ng laki. For them, advanced gastric cancer. It's already ganun. Not, because you remember that this also has a very rich lymphatic network, and it, like similar to the esophagus, it can also spread rather than okay. The extent of lymph node dissection. Pag sinasabing B1, B1 is almost always your D1 lymphadenectomy more or less very early stage. D1 plus lymphadenectomy are in C1 in clinical T1 lesions that are other than the above. Okay, so medyo bigger na T1 lesions or poorly differentiated type, etc. Okay, a D2 lymphadenectomy, this is recommended for potentially curable T2 to T4. So more or less, advanced versus advanced, D2 early, you can still do D1 plus. Okay? Spleen should be preserved in total vasectomy for advanced cancer of the upper stomach, provided that the tumor is not involved with the greater. So sometimes you will be asked, do I need to do a splenectomy? So this is one of the indications. Okay, endoscopic resection, very rare sa atin, but we will be, just so you know, we will be offering this in patients in which the possibility of harboring lymph node metastasis is less than 1%. And what are those lesions? T1A, very small, no ulceration, well differentiated. Okay, submucosal dissection, this is a bit deeper. So if it's a little bit larger, or meron ka na ulceration, so you have some risk factors that are present in the lesion. Relative indication, if you have an elderly patient with a high operative risk, severe comorbidities, if the resection is, if the lesion is small, option would be. Okay. In this part of the lecture, we'll be talking about different lymph node dissection, B1, B1 plus, and B2. So you can memorize this derecho, but I would rather explain to you the principles behind it. At least you will understand it in the long run. When you say a perigastric or a B1, these are the stations that are immediately around the stomach, these are stations 1 to 7. Okay? Download this table. Extragastric blood vessels. So when you say extra, so parang ito yung second order, these are the stations that are for your blood vessels. So you look at your station 8 to 12. Take note that in station 7, sinasabi natin blood vessels, but this is your left vessel. Okay, so because this is the main blood supply. Okay, so B1 plus or B2. Yan sila. And this is how you should do it. Afterwards, you the surgeon, because you know the orientation of the specimen, you will cut it for your technologist, and the pathologist will tell you where to pass it. So that is proper sampling, at least in the Eastern setting, East Asia. So B1, as I said, 1 to 7. How do you memorize this? Go from proximal to distal. 1 and 2, your cardiac lymph nodes. 3, lesser curvature. 4, greater curvature. 5 and 6, infrapyloric, suprapyloric. Pababa ka lang. And your left gastric inside. So 1 to 3, 4, 5, 6, pababa ka lang. And then you go to 7. With B1 plus, so dissection, this is 1B, B1B. So early pa rin siya. So hindi pa rin siya advanced gastric cancer. You can just add your 8, station 8, which is your common hepatic, your 9, which is your celiac lymph nodes, and 11P, which is your proximal splenic. D2, you will remove everything except your splenic highlight. So tinanggal na nila with the latest guidelines in the 2014. Dati ng 2014 kasama yan, now hindi na. Because they found out that more or less, if there are no nodes there, it's the same. So you just have to remove it if you have positive nodes. So it's how it gets checked. Now, pag sinabing D2, hindi lang isa yan. If your lesion is in the distal esophagus, you will not do a total. You will not do 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Well, hindi na. So, ititira mo yung 2, diba? Ititira mo yung 2. Kasi wala namang connection. So, just remember that you will not be able to memorize this now. But just remember that before you say yung lymph nodes na tatanggalin sa BP, first look at the location of your lesion. Okay? So, to wrap up dun sa B2, more or less, when you say B1, it is near the organ. B2, next level with the blood supply. B3, so this time. Okay? Proximal gastrectomy only for early lesions, sabi niya. So, in terms of the adjuvant, so you can do sa kanila outright surgery in gastric, or you can do MAGiC-TRAD by operative in NCCN. Post-op, give chemo. Yun lang naman yun. You give chemo.
Hello, Colantes. Kasi nag-rounds. Okay,
Just give chemo post-op for these patients. Okay. Just get that. And also, don't forget that trastuzumab can also be used for your advanced gastric cancer. Okay, so this is one of the techniques that you do. Okay. Last topic, just look for these keywords within Kaimal. Institution cells of Kahal. CB117, c-KIT, submucosal, KIT mutation, PGG, FRA mutation, use your imatinib adjuvant or neoadjuvant. Yun na yun. So you always give your treatment is a complete surgical resection. No need for that B2 nonsense. You just need negative margins, and that's why a wedge resection is acceptable. If you cannot, if it is borderline resectable or very difficult to resect or unresectable, you can consider neoadjuvant imatinib. Okay. If you completely resect it, and if it is a high risk lesion, you give adjuvant hematomy for high risk. Kung low risk lang, observe mo lang yun. There is a table for high risk and low risk based on your organ. So make sure you are looking at the correct table because iba-iba yung table nila. Low risk, hindi ka magbibigay dito, hindi. The rest, you give your anatomy. Okay? And you give it, how do you give it? 5 years. Over 5 years. Based on the first stage study. 5-year adjuvant. Okay, I'm very sorry I got over time. If you have any questions, you can ask it later or you can send me an email. Right in the screen. Thank you very much, and I hope that I was able to help you.
Thank you, Dr. Erlina. You may now present your questions.
Close.
The post-test.
Okay. Here you go. So, questions are up. First one, Zenkers. You know this. Second is.
So once again, if you have any questions, use your chat box or the question and answer icon. Billy, there's a question right here. Will you be giving them a copy of the slides?
Yes, sir. We will be giving them PDF copy of the slides, but after the conclusion of the entire review course. So sa huling-huli na yun, sir.
Okay, Dr. Damiles, I hope that answers your question. Thank you, Billy.
Sir.
Very interesting answers.
The intricacies of the esophagus and the stomach, no? Hindi mo makukuha sa ilang oras lang.
Yes, sir. Very challenging topic kay Dr. Emo. Yeah.
Oo. Ang hirap naman. Just to make an outline and to facilitate it is very difficult. But at least there were good tips given by Dr. Erlina. I hope the residents were paying attention. Those were good tips for studying.
Very, very difficult. Okay.
So sobrang na-answer mo na Dr. Erlina yung mga questions nila. Wala silang nilagay sa Q&A.
Mukhang wala.
Oo, wala.
Ako nga may mga questions ako eh. Yeah, really, preparing for this lecture, as you saw, I had to look, very frustrating. I remember as a resident to look at, you have to look at different sources, nagbabago yung data, ang daming points of view, ang daming nag-aaway about best this or best that. Tapos, on top of that, the patients are also toxic. So, yeah, I hope that this urges some of you to go into this or study this because I'm really afraid that yung gastrectomy and esophagectomy would be a forgotten skill, forgotten art. Lalo na, di ba, kumonti na nga yung cases na.
Palagay ko, oo.
So, yeah, but that as it may, patients still need it. Hahanapin ko.
Actually, Dr. Emong, yung gastric and esophagus, in some countries, it is already a subspecialty.
Yeah.
So some other surgeons don't even want to touch that area anymore. They refer them to subspecialists who specialize on esophagus and
Yun
gastric.
lang. As in, esophagus lang. Stomach
Yun
lang.
ang ginagawa nila.
Yan sa ulo na eh, sapat na.
Okay, so I think, sir, pwede na natin itong 60%, malapit na. Sige, paabutin natin ng 5 minutes, sir, tapos end call na natin.
Okay.
Kung marami na yun, 60% na yung nakasagot halos.
So, we have a question from Dr. Raisa Fontanilla. For GIST with liver mets, but with moderate to massive bleeding, what would be the ideal management? Can embolization be considered? Then, imatinib na lang, or do we consider resection?
Right. It will really depend on how resectable your massive lesion is. So in that case, if the tumor is still resectable, massively bleeding, you could be justified, if you can do it safely. Do a resection. Your problem is if the gist is very big and you cannot do a safe resection. Well, you can try to devascularize the tumor with what you said, no? Angiography, or hopefully baka endoscopically kaya if it is in the lumen. But yeah, that's very difficult. You can try it, but I don't think it will really depend on the amount of how strong the bleeding is. So chances are your best option would be number one. If you can resect, palliative resection. If not, try to devascularize the tumor, but baka that will not work. It will buy you some time, and then hopefully just give imatinib if the patient can still tolerate it. Pero mahirap, very challenging. I think si Doc Billy, there was one case that there was a pancreatic involvement, and I don't think that they were able to resect kasi extensive. Do you remember that, Doc Billy?
Pero usually kasi pag bleeding gist, as much as possible, kasi gist so you try to, pag bleeding talaga yung problem, kahit na yung mets na siya, you try to control the bleeder. So resect or devascularize, yun lang talaga. So you have to go in and do something kasi kundi mamamatay din yung pasyente if you don't do something. So
or indeed, of course, there's also the option of
interventional radiology, one other option then. We can refer that. Maybe they can embolize it, but that still depends kung kaya nilang gawin.
And on the other hand, nandiyan din yung sa pinakahuli, of course, multidisciplinary, cancer patient, individualized therapy. There's always that option of not, in the very, very, very difficult option of there's no harm in all of that. So you have to look at the extent of your bleeding, look at the patient, look at the attitude of the patient, the habitus, baka naman kahit pagbigay mo pala ng anes, because these patients would have poor nutrition for them to reach that stage. Hindi na makakakain yan. So baka poor surgical cancer yan. So there's no hard and fast. Baka i-technical ka, biglang bagsak pa rin katawan. Sasabihin sa'yo, sandali, tingnan mo muna kung kaya ko. Okay.
Agree. Okay, I think, sir, we should end the poll.
Thank you, Raisa. Thank you. I hope that answers your question.
Thank you.
Okay.
Do I discuss? Mabilis lang.
Yes.
Hindi na ba? Area of weakness, alam niyo na, 90% of you got Killian's triangle. So, that's good. Ito, the Poiseuille's law, no? I'm very sorry that I had to put in some physics in it. But I wanted to stress in length, okay? It really counts the length of your intra-abdominal esophagus in the success of your reflux. Because yung mga pinakita ko pa lang are the successful, ang gaganda ng drawings, no? there are topics, there are chapters in the book about failed fundoplication. And this is one of the most common reasons, yung insufficient intra-abdominal esophagus length. Okay? Kaya nga pumasok yung collis gastroplasty. So length, always length. Pressure difference and radius. Radius, volume flow rate. Remember, no? If your radius is small, mas konti yung makakalusot. So, inversely related. So, radius is directly related to the flow rate.
Mm-hmm.
Posterior, okay, tupay. Sikat na sikat yung tupay. EMR, recommended for gastric adenocarcinoma, except when the lesion is sorry, hindi ko na-discuss masyado ito, but yeah, ulcerative is the high-risk feature. So, buti na nakasyon mo yung kanina. And then the standard dito dissection. So, this is the new one. Ito pwedeng talagang discussion ito, mahabang discussion ito, but they removed yung sphenic hilar dissection standard in the B2 dissection. Okay? So, yeah, maraming discussion dyan. Okay, so, yeah, congratulations to everyone who answered the questions. I hope you learned something today.
Thank you very much. Thank you. Thank you, Dr. Lina.
Thank you.
Very comprehensive lecture. I really hope everybody learned from it. So I think you have to rush off. Thank you very much. I hope you enjoy your day.
Salamat, Doc. Thank you for the invite. Thank you.
Thank you. Ayan, so of course, as I mentioned earlier, I think Dr. Castro will not be able to join us. So on his behalf, Dr. Uy will be presenting the lecture. Dr. Uy?
Yes, sir. Good morning pa rin. So, it's
Morning
good.
ulit.
Yeah, morning pa rin. Okay, so just let me prepare, sir.